Welcome to the Iron Prescription podcast with your hosts, Doctors Lynette and Stuart. We're both GPs and we're both personal trainers, though we do both jobs in very different ways. We chat about the best things you can do for your health and fitness, and along the way, help you to avoid wasting time on the things that really aren't. Thanks for listening. So, we are talking about cancer today, aren't we?
We are talking about cancer, the big C.
And it's probably fair to say from the outset, we're not here and about to tell people that the fitter you are, the more bulletproof you are against cancer, because that would not be truthful.
No.
But like with all things, there's nuance.
Yeah, absolutely. You're definitely not bulletproof, and I can attest to that. Having had cancer myself in the not too distant past. 2023 was my operation, yeah.
So that's really recent. Okay.
Yeah. But do I think, so people say to me, oh, I thought you said that like fitness and everything, I thought it like protects you from all of that. And I think that fitness does protect you from all of that, but it doesn't make you bulletproof. But I can absolutely 100% say that I truly feel that my recovery and the side effect profile that I've had from my cancer is there's a direct relationship between that and sport and fitness. So I think I did better. The fact that I went into it really fit.
So going sideways slightly, because I don't actually know much about your story and I'd be interested to hear it in its entirety. But in preparation for this, when we said we would talk about it a few weeks ago, I said I would listen to Chris Hoy's latest book. Because like many people, when I read the news about Chris Hoy's metastatic prostate cancer diagnosis, my thoughts were, how can that happen to someone like him? Extreme elite athlete in the prime of his life. This can't be right. And his book is worth a read if you're a cycling fan. I think what's very clear and what he was very upfront about is he didn't have any symptoms.
No.
He had a pain in his shoulder and went for a scan, fully expecting to be told he needed to back off in the gym. And then his whole world pivoted and has gone in a different direction from there. He and you are proof that, you can be fit and it doesn't make you bulletproof. But in terms of your experience then, as somebody who is fit, and as you said in the last time we recorded an episode, you can be a bit prone to over-focusing on symptoms. How did your diagnosis get discovered?
So I think what's really interesting is when I look back, so I had prostate cancer, the same as Chris Hoy. Thankfully, mine was not metastatic and I am not in a terminal disease state currently. I say currently because that's what it is living with cancer, a period after having cancer taken away from you where you're not actually quite sure whether or not you've got away with it. And with prostate cancer, that is a 10-year window where they keep you under review until they say, no, you're clear. Anyway, but as I said on the last podcast with health anxiety, the thing that's going to catch you isn't the thing you think about. And I didn't pick up my cancer because I was thinking about prostate cancer. I picked up cancer because of the kind of doctor that I am, which is I'm much more the same as I am with sport. I'm much more trend driven as opposed to absolutes. So I don't look at a single number. I love a trend as opposed to a definitive number that says yes or no. And PSA, which is prostate specific antigen, in my case, had began to drift from a very stable number to a number that was changing and had, although it was still within the normal range, it had more than doubled from what it was. And that trend is what led me to go, what's going on here?
Okay. So I know there'll be people listening to this going, but why were you measuring your PSA? And as a doctor, I want to know why you are measuring your PSA, because
Right.
my first question to a man who comes into my clinic and says, somebody at the golf club's got prostate cancer, do I need to get a PSA test? I will always pause and say, hang on, it comes after your symptoms. What symptoms have you got? Why are you concerned? And there needs to be an exploration of what we're looking for. That used to be right. That may have changed. I
Yeah,
don't
yeah.
see many male patients anymore, in fairness. My clinics are overwhelmingly female. But in your case, what were you doing measuring your PSA in the first place?
So interestingly, my performance from an athlete's perspective, I was, as we've discussed with the podcast, I'm always looking for marginal gains, and I'd done several Ironmans, and I wanted to know if there's anything that I was missing. So I'd had a profile done, including testosterone, and my
Yeah.
testosterone was incredibly low, and I therefore ended up, after investigation, and had primary hypogonadism, so I just wasn't producing testosterone in the levels that I should be. I went on to testosterone replacement therapy that we've talked about on the podcast, and that uh, has a caveat to it. Now, we know that prostate cancer is possibly driven by testosterone. There's a lot of science around this, and I'm not going to get bogged down talking about that in this episode, but there is one of the treatments we have for prostate cancer is to completely block testosterone in an attempt to stop it growing. Now, testosterone doesn't cause prostate cancer, but if you do have prostate cancer, the concern is that you're driving the cancer, you're fueling the cancer. So there is no correlation between testosterone levels and prostate cancer. In fact, the opposite. So people with low testosterone are more likely to get prostate cancer than people with high testosterone. So, for example, we don't have waiting rooms full of bodybuilders
Mm.
saying, "Oh, I've got prostate symptoms." In fact, the opposite. They seem to get away with it. But if you're on testosterone replacement therapy, one of the caveats is that you must have annual PSAs. So that's why I was having my PSA
Okay.
measured.
Okay.
And I saw a rise from, so the normal level is 0 to 3.5. I say 0, but you would expect a number to 3.5 is the normal range. And I was measuring at about 1, and it went to 2.26. And I said to my GP, who's also a good friend, I said, "That's a bit odd." And he said, "Yeah, it is a bit odd. What should we do?" I said, "Let's ask another mate who's a urologist." So I asked another mate who was a urologist. He said, "Oh, God, you doctors.
Yeah, I'd have said that.
Yeah. Oh, you boy doctors. Oh, dear. I expect you want an MRI."
Mm.
I was like, "Yeah, I'll have an MRI."
Go on then.
So go on then. I had the MRI, and then the MRI is measured by something called PIRADS, a scale which is 1 to 5. 1 and 2 is normal. 4 is a possible cancer. 5 is a probable cancer. And 3 is, and mine was 3.
Oh, flipping out. How
Um,
anxious were you?
oh, it's totally not even a thing. Not even a nothing. A
Okay.
nothing. In fact, the MRI, God, I love the NHS. The MRI, I'd had the MRI as an urgent, and I hadn't heard anything for 6 weeks. And I was like, and I literally thought one day, oh, I better text Jan about that MRI result because I presume it was normal.
I would think the same. And I
Yeah,
say to people,
it,
generally, if there's something to worry about, they'll find you.
yeah. And I texted her and I went, MRI results, I presume, are normal. And she went, oh, I've not heard anything. I'll
Mm.
chase it. She was like, if we've not heard anything, not, I expect it's normal. They hadn't reported it yet because of the backlog. And anyway, they got around to reporting it. And then she said, oh, it's PIRADS 3. And I was like, she said, oh, should we do a biopsy? And I was like, oh, really? She went, what else can we do? I was like, okay. So we did a biopsy. and she did a local biopsy, which is not the gold standard. And she literally phoned me up at work and said, "Don't worry, but you've got cancer." I was like, "Don't worry." And she said, "Yeah, it's not going to kill you." And I was like, "All right, great." And I then
Oh,
added,
I'll finish my
I,
shift then. See ya.
yeah, I'll finish my shift then. I was like, "All right, okay. Should I have a different biopsy?" She went, "Well, you can if you want." And then I had a biopsy under anaesthetic, which is a template biopsy, which takes a lot more samples. And then they went, "Bad news, it is going to kill you, but it's not going to kill you straight away. You got time to have a think about what you're going to do." And I really struggled with that decision because there's lots of courses of different treatments for prostate cancer. And prostate cancer is predominantly an older man's disease, but Chris Hoy was 48. I was 52 at diagnosis. And when you're playing if you're 70 and you're playing for 10 years, then the treatment is different to if you're in your 50s or your 40s. And I agonized about the treatment. You can have radiotherapy delivered by a pellet. Well, first of all, you can do nothing. You can just sit and wait and see if what we're going to do is watch it every 6 months and see if we can catch it before it spreads. That didn't sound like a great idea to me.
It'd be a rare individual in their 50s who would just go, "Yeah, I'll just carry on."
Let's just
Yeah.
see how we go. It's rock and roll. The other thing is that cancer generally in younger age groups tends to be more aggressive. It tends to grow quicker. I didn't really fancy that idea. Then they can give you localized radiotherapy via pellets, and they leave these pellets in and they emit a radiation into the prostate over a period of months. And they've got a really good success rate. But that success rate, they don't really know what happens after about 10 years because normally they give it to older guys. And then there's something called radiotherapy, beam radiotherapy, where they give huge amounts of radiation to the prostate via a beam over several different weeks, and you go so many days. And that's a lot of radiation into your body, and there is a risk of secondary cancer as a result of the radiation. That didn't sound great. And then there was a very high dose, but over a shorter time period, only over 5 days. But then there's, again, we don't really know what happens after 10 years. There was something called HIFU, which is basically, for want of a better word, when you look at the literature, looks like to be a bit magic from Mr. Bean. It's high intensity frequency ultrasound, and they heat it up like it's in a microwave. I think that's very good for cancers that were never going to kill you, but it's not very good for cancers that were going to kill you.
Right.
So basically, it's good at succeeding where there was never a problem. So I didn't like that idea, and that left me with prostatectomy, a radical prostatectomy. Now, the problem with the prostate is that it's wrapped in a pith like an orange, and that pith in the prostate is a nerve bundle, and that nerve bundle is entirely responsible for your erections. And without that, it doesn't matter what drugs you take, you're not getting an erection. That really worried me. That was a real game changer. The thought at the age of 52 that sex life would be over was an issue. And so I I met with 4 different surgeons. The first surgeon, who was a very competent surgeon, said, given where the tumour is, I give it a 70% chance that you will have complete erectile dysfunction.
Great.
Non-reversible with drugs. I was like, oh, great, fantastic. But I went into all sorts of, into the fine minutiae, the detail of prosthetic balloons being put into the penis for artificial erections. And I went in great detail. And then I came across a guy called Nick Vazdev, who is a surgeon in the east of England. And for the first time in all the consultations I'd had, he treated me like a patient. He didn't treat me as a doctor. He treated me as a patient. And he went, no, look, this is better in a bucket. You need this out. you don't need to be worrying when you're on the start line of a triathlon, whether or not that back pain is back pain because you're an idiot and you do triathlons, or actually it's your cancer spread. This needs to be in a bucket. And you don't need to be worrying about that erectile dysfunction. That's my job as a surgeon. I need to worry about that, not you. And I'm going to do an operation where I'm going to go through the prostate. And as I go through the prostate, I'm going to take tissue samples until I can get as close as I can to those nerves. And that is something that hadn't really caught on in the UK health arena. It was very popular in America, but it hadn't caught on here. I went with him and I went to theatre. I was in theatre for hours, and I can remember the next day he came around on the ward rounds. It's done by robotics, so it's a robotic assisted. So he sits in the corner on his game station, PlayStation, with his controls, and doing his wizardry, not even touching me. I'm hanging upside down. So with the prostatectomy, because the prostate sits inside the pelvis, what they want to do is try and get as much room as they can. So what they do is they put you on a tilt table and they tilt you back head down, so that all your abdomen, it comes up against your diaphragm, so it gives him as much room as possible in the pelvis. So I'm hanging upside down. I don't know anything. I've had a general anaesthetic. I'm completely out of it. And he carves as close as he can to the nerves. And the next day, comes into the room. I'm off my face on drugs, completely off my face.
Good.
Yeah, absolutely.
I'd want to be. Give it
Yeah,
me all. Yeah.
I was like, yeah, I'll take everything.
I
You
would.
know, everything.
Don't hold back.
And he came in with his entourage, with all his doctors and his medical students and everything. And this like whole tribe came in with him. And he said, "Morning, Stuart." And Joe's sitting there. My wife's sitting there next to me. And "Morning, Stuart. How are you?" And I'm like, Nick, I've had morning glory."
Oh, God.
My wife's, oh my God.
I was going to say, poor Joe
Oh
probably
my
died
God.
1,000 deaths.
Yeah. And like even the medical students are like, but yeah, so he'd managed to spare the complete nerve bundle, which is amazing. And then the next problem that you have with this operation is that it not only does it affect that, but it also affects the bladder neck. And the bladder neck is a muscle and a sphincter that they have to pull down, they have to stretch, and it's all about the pelvic floor and the pelvic floor muscles. And you can some men end up not only completely irreversibly impotent, but also incontinent. And some men sadly end up with a catheter because they're unable to control the urine anymore. But because of my level of fitness, I was undoubted. I can remember, and if Nick listens to this, he'll be like, "Oh my God." Because he'd said to me, I will do my bit, but you need to be on board with your bit and you need to rest. And because the sutures that I'm putting in are very delicate, and what we don't want to do is try and do a repair. And I was like, "Yeah, no, fine." And I said, "You did say I could swim after 3 weeks, didn't you?" And he went, "No, Stuart, 3 months. You can swim after 3 months. Swim. You can't run or bike for at least 6. And I'm like, "Oh, all right, okay." Anyway, I think I was about 4 or 5 weeks after the operation when I did my first run. And I decided I was going to see how far I could run. And I was astounded about how incontinent I was. Every stride I took, I did 2 miles, and every stride I took, the urine was just pouring out of me. And that was a real wake-up call. And I was like, oh my God, this is awful. So,
but you were going against medical advice, so it serves you right for pushing
yeah,
it.
absolutely. So I had my operation in the May, and I sent him a picture in September of me completing the Serpentine swim in London, which is a 2-mile open water swim, which was allowed. That's 3 months, surely, May to June to July, just. And I'd done 2-mile swim, and he was astounded that I was able to do the 2-mile swim. I did follow his advice after that, but actually, I am now completely 2 years, and they don't actually measure the incontinence level until you get to 2 years. I'm now 2 years. And because of my core and because my pelvic floor was in such good shape, I am totally dry. I'm completely continent. I don't have an incontinence issue at all, not even on a trampoline, which is absolutely staggering. And as we spoke on the last podcast, I did it with no training. And when you see other guys that have gone through prostate surgery, the stories are devastating, absolutely devastating to the effect that it's had on their life post prostatectomy. They can't leave the house, they're incontinent, their sex life is completely gone. And it's all about, I had a fantastic surgeon, there's no doubt about that. But even Nick will openly say he does his very best for every patient, but he can't, he just can't do miracles. And he tries his very best, but he is only a surgeon. He's not some godlike figure, although I thought he was at the time of my operation and still do. He would definitely attribute my recovery to the level that I have been able to recover as a result of fitness. And all the research would back that up.
Yeah, it brings to mind a few issues, actually. I haven't experienced cancer myself, but the difficulty people have at the point of diagnosis when they're given options, I think is a real struggle for
Yeah,
people. I
yeah,
can clearly remember when my mother-in-law got diagnosed with breast cancer and they said, you need a mastectomy. You can either just have the mastectomy or you can have a tissue reconstruction using muscles from your back, or you can have an implant, or we can do all of that at a later date. And she was completely floored. She wasn't
yeah,
to make a decision. On the one
no,
hand, you're trying to process the diagnosis.
yeah,
And for her, I guess it was slightly different in that the decision about the treatment was made. She needed a mastectomy. But there's still all these kind of downstream decisions to be made at a time when, and she's not medically trained. It was really almost impossible to know whether you're making the right decision. And I think for you, having an advantage of medical knowledge and understanding the literature, how difficult did you find it still? Had you not
horrendous.
found that surgeon? Yeah, it must
Yeah,
be a
horrendous,
really difficult
horrendous.
thing.
I was in an incredibly fortunate situation. I got the ability to seek multiple avenues. I'd got the ability to read the literature and understand it myself. I'd got the ability to not listen to, and there is so much, for want of a better word, crap out there.
Mm.
We can cure your prostate cancer with, what was the best one I heard? It was something to do with tea, peach tea or something.
It doesn't surprise me. It
No,
should, but it doesn't.
yeah. And sadly, the bots in your computer learn what you're searching,
Mm.
and then they throw at you the crap as well as the good.
Mm.
So I would get feeds on my Instagram telling me of this new therapy for prostate cancer, and I'd be like, I'd have to go and look at it. I'd have to go and research it, and and if I believed the first line, then I'd be cured by the evening. I find that incredibly cruel of the web that it's that to happen.
Mm.
And obviously stop that because it can create it, so it must be able to stop it. But we don't seem to be invested in doing that.
Yeah. I think the other thing it reminded me of as well is this swinging emotion that I've seen people have between, on the one hand, they're grateful that there's a surgical option because without it, it's death, certain
Yeah,
death. But then on the other hand, you have to consider the reality of life with potential long-term side effects from the
yeah,
surgery. And I think for women with breast cancer, which is probably the most similar in terms of its relationship to
yeah,
hormones and degree of incidence, how often we see it, it's the most common cancer. But for women, the kind of psychological effects and the impact will hit once the reality is, okay, I am still alive, but now I've got to live with the effects of the surgery. As you say, the fear that it's going to come back. You never meet anybody who's had cancer who doesn't
no,
have it sitting on their shoulder
yeah, yeah.
forever, I think.
Yeah, I think, the mental impact was huge. I talk about health anxiety, but the health anxiety, as I discussed last time we spoke, health anxiety isn't about health, it's about anxiety. It's just attaching itself to health. When I look back, interestingly, unlike Chris Hoy, I would say I definitely had symptoms of prostate cancer, but I they'd happen, and this is what happens with prostate cancer. It doesn't happen. It is a slow, really slow burn, and it creeps up on you, so you don't notice it. But when I look at urine flow is an absolute one that these, as doctors, we say, have you noticed any change in your urine flow? And if you'd asked me before, I'd have gone, no. I can tell you there's a massive difference between, because now my flow, it doesn't have a prostate in the way. I can tell you there's a massive difference between that and now, but I couldn't have told you that then. So it was really interesting from that perspective. And the guilt that I felt towards my family was horrendous, that I'd let my family down by having cancer, that I'd somehow, prostate cancer isn't something that you can say, well, I did this. It's as, if you were a smoker, you could say, I wish I hadn't smoked. Prostate cancer is just something that a lot of men get and a lot of men die of. And we're not really sure, apart from genetics, why that is. But I felt that I'd absolutely let my family down and was devastated by that.
I think a lot of people who've survived cancer will relate to that.
Yeah.
That's much more common and not readily admitted, I
No,
think, because it seems so. People who haven't experienced it probably wouldn't be able to rationalize that, because it isn't rational. It's not coming from the rational part of your brain, is it?
My family were like, my older children and Joe were like, but you're alive. That's what we want. We want you to be alive, and you are alive. And that's all that's important. And I spent hours talking to good friends and really agonizing about this horrendous guilt that I had and that I carried. And it's part of the process of cancer. Like you say, it's very common. This guilt is very common. But so there was a mental impact. But again, I think that sport, I would be able to process that by doing things physically. And it helped me as a kind of therapy to be able through that. It's interesting what you say about the side effects and about that agonizing about the side effects and what you're left with. I have spoken to men afterwards who have openly said to me, I wish I was dead rather than living with what I've got left. So we've cured the cancer, but the devastation of the side effects that they've been left with, in their mind at the moment, is worse than having the cancer.
That's a horrendous thing to hear as a doctor, because ultimately most of us are fixers and problem solvers.
Yeah.
And we do what we do in an attempt to help people. And you would think, yes, you're alive, but I do get that. It's nothing. I would really, not that it's my problem, I'm not living with it, but I can just imagine feeling quite helpless. We don't like feeling helpless as doctors. We like to have an answer.
Yeah, it's interesting. I think there are a lot of answers. I think that there is a lot of sexual inequality in prostate cancer against breast cancer. So if a woman has breast cancer, we recognize that her breasts are part of her personality and her presence and make her feel a woman. And we therefore immediately offer, as in your mother-in-laws, we offer them reconstruction and several different types of reconstruction. And we offer them things like tattooed nipples, which are incredibly realistic. We offer lots of things about that. But with a man, there's none of that. So I had to go to Harley Street to speak to a surgeon who could offer me a prostatic implant to achieve an erection. Now, part of the huge psychological element of erectile dysfunction is that it really does play on a man's mind of what are you if you can't achieve an erection, because it's associated with everything about being a man.
Being a man, yeah.
And we're surrounded by that sexuality in modern society. But we don't offer that to men routinely in the NHS. It's only available as a private option. And also, I find that urologists are, even my urologist, who was absolutely amazing, I'd seen several before that, but the several before that were absolutely rubbish at imparting knowledge about those options. It was only when I got to Nick who said, oh, even if it goes completely wrong, we've got an answer. And I was like, you've got an answer? Yeah. Because, and I'm not just, there may be people listening to the podcast now, so I'm going to tell you about it. When a man is unable to achieve an erection, what they're unable to achieve is a mechanism of penetration or an organ that can receive stimulation to achieve a climax. They are not robbed of the nerve sensation that achieves a climax. They're only robbed of the tool. So you
So the
still have.
mechanics, it's the mechanics, not the,
Absolutely.
yeah.
Yeah. So
Yep.
the mechanics of an orgasm, the nerve stimulation that achieves an orgasm is still there. But if the erection is not present, it's very hard to achieve that state of nerve stimulation, and it's impossible to achieve penetration with a partner. And an erection is achieved by blood engorging a large vein in the penis, and then that vein being clamped off and to achieve that erection and maintain that erection. And that clamping does not release normally until climax is achieved. What I didn't know, even as a doctor, was there was, first of all, a vacuum pump that you could place around the penis that would basically suck that blood in, and then you could attach a ring over the top to stop the blood from leaving, and you would achieve some kind of erection. But there were also 2 surgical implants available. One is where you have a third testes, and you pump it up through the testes, like those old Reebok trainers who used
Oh
to
yeah.
carry, or a skiing helmet. The skiing helmet's where you pump at the back and it gets larger.
Right.
Exactly the same thing.
Okay.
And then you have a valve, and basically that pump is pumping saline into that vessel. Or there's a posher version where actually the pump is in your groin in a button, and you press a button and hello,
Okay.
erection is achieved, and very high success rate. But I don't know if you've ever told a patient about that.
No, I didn't know about the implants. I knew about the vacuum pump only
Yeah,
because I'd had a patient who'd been offered it and
yeah,
he didn't get on very well with it. He didn't
no,
find it very successful, but
yeah,
that's one person
yeah,
in
yeah,
however many years.
yeah,
Yeah.
absolutely. But we don't offer that on the NHS, and I think that's such a shame, because that is one of the major psychological issues as a result of prostate cancer that men face. I think that I'd done so much research about it and seen so many people that I'd really got all that information. And that's thankfully as a result of being a doctor, because I was like, right, give me more. And I was able to go, actually, no, I don't like the way you're talking. Because there was a lot of salesmen, amount of salesmen saying, oh, come to me, I am the answer. But
Yeah.
I think I definitely still think sport gave me a huge advantage in the recovery, and it helped me process the information a lot better than I was able to do in any other way.
Yeah. I think I couldn't imagine there's many people who would start a brand new fitness regime at the point of getting a cancer diagnosis. But what is emerging is prehab, which I've
Yes.
spoken online about
Yeah.
quite a
Yeah.
lot. And prehab is getting yourself fit for surgery.
Yeah.
And it doesn't need to be a marathon or an
No.
Ironman,
No.
but it absolutely, the evidence clearly shows that the time you spend preparing your body for the stress of surgery by training
Yeah.
beforehand will pay you back in recovery.
Absolutely.
The cancer charities have got on board with it.
Yeah.
So it's out there and it absolutely will pay you back.
Yeah.
And as we've said before, the psychological benefits to exercise, managing anxiety, clearing your head, giving your body something to do other than your mind, sorry, something to do other than just dwell on things. There's an element of needing to process what's going on. Then there's ruminating and there's catastrophizing. And I
Yeah.
think physical activity is the best antidote to that you can
Mm.
do on a daily basis, definitely. But
Yes. I think there is no, other than if you're going in for cardiac surgery, I would suggest you need a very tempered program and a very specific program for you. But there is no wrong time to start doing fitness in that journey. And the sooner you start, like you say, the better the recovery. And also coming out the other side and using that as part of your recovery. Recovery is not about sitting down and doing nothing. You've got to have an active recovery. Now, I'm not saying you should do it the way I did it. And
No, I wouldn't endorse that either.
I'm sure when Nick hears this, I'll get a text message saying, you did what? But I think there is definitely a part of the journey that needs to include fitness.
And Chris Hoy's talked about this quite a bit in his book, and I wouldn't expect any less from somebody who spent their whole life being an athlete. That's unlikely to change at the point of this. One of the interesting things which I hadn't considered, which he makes a point in the book, is the administrative burden of being a patient and how he wouldn't have coped without his wife to help him. And I'd never thought of that because I guess as a doctor, I'm part of the admin problem to begin with, right? Can you come for this appointment? Can you make it here? And he said he found that absolutely overwhelming. And I thought, okay, I need to take that on board and remember that because it's huge. And for people who are working, we've had staff who've needed time off for radiotherapy, chemotherapy. They don't want to take all of that time as sick. And there are all these downstream things for people to consider.
And I mean, I was treated differently because of they knew I was a doctor. And one of the classic was I came home. You come automatically after a prostatectomy, you have a catheter in for 10 to 14 days. And I came home with a catheter in, and one of my really good mates is a nurse. She's a sister, and I'm a doctor. I have very little to do with catheters. I might put a catheter in, but that's the end of my catheter care. The nurses had let me go. They were brilliant. The nurses were absolutely brilliant, but they'd assumed that I knew what I was doing. So they'd sent me home with Joe, who also thought Stu knows what he's doing. So had taken direction off me. And then quite innocently, and was doing a fantastic job. She did an amazing job, given the fact she's got no formal training. And then Rhonda turned up and went, what the hell are you guys doing? And we were lucky that this cold catheter event hadn't gone absolutely catastrophically wrong. She's what, no, stop. You don't do that. And I got my night bags mixed up with my day bags, and I'd got this plug unplugged, and how I didn't get urosepsis is beyond me, but it's probably down to the fitness. I was like, oh yeah. Oh, and wound dressings again. I was like, again, I hadn't really. It's done by another healthcare professional, and I am not that other healthcare professional. But luckily, I had those other healthcare professionals around me.
Yeah. And this is a really common problem. I know most people listening won't be able to relate to that, but the assumption that because you work in one sector of the health service that you'll be competent in others is a trap that we're all guilty of falling into. I certainly did it, having the kids, and I know what I'm doing having a baby. I've done loads of baby checks. I knew no more than anybody else.
No,
arrogance.
And all I wanted to do was, of course, was get home as well. It's gonna
I don't need painkillers until you get out of the car. Yeah, absolutely. It's probably worth just touching on, in case we've planted the seed of PSA in people's minds who are listening to this, in that, so Chris Hoy has been very vocal and is pushing for better access to PSA for men generally. It's worth just saying we don't have a screening process.
Nope.
Only because there hasn't been shown one that's consistently met the right criteria consistently enough to satisfy what a screening test needs to be in that. And that is why. So PSA isn't a screening test, and that's why it's not routinely offered. It has a high false positive rate, and therefore many people will be sent off for investigations unnecessarily, and that's why it's sitting there. But if you've got symptoms, the best thing really is to talk about it with somebody who knows about it.
I think so. I'm going to slightly challenge you there and say that PSA is not a screening tool as an isolated figure. I think that the answer is that men should have an annual PSA and look for trend analysis. PSA, prostate specific antigen, is a number that goes up with age normally. It goes up with benign hypertrophy, so that means enlargement of the prostate that is not cancerous. It goes up after sex. It goes up after you ride a bike. It goes up after stress, and there's some evidence it goes up after high intensity training of any sort. So, however, I think trend analysis is far more common, so far more indicative of a problem. I think anybody who has a PSA that's outside the normal range deserves an MRI. Um,
They will
the,
do that. I think that's
yeah,
fairly standard now, but the problem seems to be who gets the test in the first place
yeah,
and how then reliable is it when it's borderline, because
yeah.
the high
So,
ones are straightforward.
yeah. So I think the other thing that should be said, if you have a normal PSA and you have symptoms of prostate cancer, it doesn't mean that you don't have prostate cancer.
Yeah.
PSA is not a diagnostic tool.
Yeah.
It is merely a marker of where we are now. So I'm still having PSAs after having my prostate because actually I shouldn't have PSA. So we're looking for, if I've got PSA, where is it coming from? And that would suggest that I've got the cancer has come back somewhere.
I have
Um,
seen that. I did have a patient who'd had a prostatectomy
yeah,
and his PSA started to rise out
yeah,
of nowhere. Yeah,
yeah.
that's
So
right.
it is, in fact, it's rebound or so PSA rising post prostatectomy is sadly quite common. And I'm definitely not out of the woods. The further you get away from day zero, the better. So for the first 2 years, I had my PSA checked every 4 months, and now we're at 2 years. I have it every 6 months, up to 5 years, and then after 5 years, I go to once a year, up to 10 years, and then I'm done. PSA, therefore, depending on what the number is, we watch it again. We wait to see what it'll do because the immune system might deal with it on its own. But back to my point. So I think if you've got a family history um, of breast cancer, prostate cancer at an early age, you probably want to know what your genes are doing for you. My mum had early breast cancer, and that's associated with BRCA gene, and so is early prostate cancer, and that led to me having genetic testing. Now, we could talk about genetic test
Mm.
podcast in its own. It's not just as simple as saying have genetic testing, because what are you going to do with it once you have the information? But if you have that, if you have early prostate cancer or early breast cancer in your family, then I think you should definitely be having a PSA from the age of 50, if not 45. And if you are Afro-Caribbean, you should be having a PSA from the age of 45 on an annual basis and looking for a trend. And if it gets above the limits, then you should then be looking for an MRI after that. I don't, and an MRI is not, again, we've got this grey area of PIRADS. The problem comes when you start having biopsies, because biopsies carry a risk of ultimately death, because you can get sepsis and you can actually die from a prostate biopsy. Very rare, but it is possible. But I think until we have a definitive um,
Screening
test
program.
screening program, which looks like it's probably going to be MRI. All the research, the
Yeah.
latest research suggests that we're going to have the same mastectomy. Instead of having a mammogram,
Mhm.
women have, you're going to have a pelvic MRI, and that's going to look for early cancers. But until we get there, I do honestly think that PSA on an annual basis and looking for trend analysis is the best that we've got.
That's all we've got, really.
Yeah,
It
yeah,
is all that we've got.
yeah.
I would
But
add to that.
yeah, if it's high,
Yeah.
it doesn't mean that you've got cancer.
I also think there's value in scoring your symptoms, and
Yeah,
not many people use it, but there is something called the International Prostate Symptom Score. And I think for all it takes to fill it out and score your symptoms, because it might prompt men to think about symptoms that they haven't thought about before, that they've just got used to, as you alluded to.
yeah,
And if you do that once a year, it's something, it's some
yes,
data point that you've got to refer back to.
yeah. And I think, yeah, absolutely. And I think now, just to make that clear for the listeners, that's different to the screening tool that's on Prostate Cancer UK. So the charity website has a screening tool that you fill in, and if you fill that in and you are over 50 or Afro-Caribbean and over 45, it will say you're at high risk of prostate cancer. That's the end of the test. Below that, it's looking for symptoms below those ages. So immediately, if you are in those age groups and those of that ethnic background, it will immediately score you as high risk. I don't believe you are high risk. I believe you are of a risk that justifies a PSA.
Okay.
Would be
Yeah.
my... So I don't want the guys who are listening to this to be alarmed, or the wives of guys to be alarmed by this. Prostate cancer is a curable cancer. It's one of the curable cancers, very curable if you catch it early enough. And therefore, I would still, after all the information I know and everything that I've talked about this evening, if somebody said to me, what should I do? I'd say annual PSAs. If you've got a trend, act on it. Looking back, I'd have probably waited a bit longer for mine. I don't think it had done any difference to my outcome. Wait until you're over the barrier of the cutoff zone, and don't be scared of having a prostatectomy. Ensure that it is robot assisted. The vast majority are now. Look at your surgeon's results. Talk to them about alternatives if they can't save the nerve. And I do believe it's better in the bucket
Yeah.
in the young age group.
Yeah.
I think that's easy. That's very easy for me to say, sitting here with my nerves intact and
Everything working.
and everything working. I still, in my heart of hearts, believe that is the right thing to do.
Okay. Great. Okay. Let's close on that.
Fantastic.
Thanks. Very good of you to share that story. I think a lot of people get value from it. Thank you for that.
No worries. Thank you.
We'll see you next time.